Hi students, I welcome you all to Obstetrics and Gynecology with Makla. So I welcome you all to the best innovation which we have brought in Makla. So you all know that in Makla we have Makla Solve, where the questions will be presented to you in the community sections and you will have to answer the daily MCQs which are released in the Makla Solve. And Makla Blinks is a platform where we used to give the most important blinks as important points for your examination in short term. Let's say, for example, what is the most important CNS tumors and their histopathological features. So we have given it in a very concise form. So similar to that, the new innovation which we are here to brought to Makler is Makler Clinical Case Solve. So here, what are we going to do is we are going to make some important clinical notes. That is, whatever topic we discuss, in every such topics we have some clinical important points which we need to remember, right? So when you are going to sit in a clinic or in your hospital as a clinician, it is important for you to remember certain important points with respect to that topic. So those important points will be gathered and it will put in a form of clinical case scenario, and this scenario will be solved by you and me here. So this is the basic of this clinical case solve. So we are going to solve a clinical case in each of this clinical case solve, and we are also going to annotate the most important clinical points which you need to remember regarding to that case. Is that clear? So let's start with the first clinical case solve of Magla. So the first case is with respect to gynecology, right? So here we are about to discuss about PCOS and ovarian hyperstimulation syndrome. So this case scenario is related to PCOS and ovarian hyperstimulation syndrome. So let's start with the case. So a patient is coming to me. She is a 28-year-old female, a known case of polycystic ovarian syndrome or polycystic ovarian disorder. She is complaining of infertility. That is, despite 1 year of unprotected coitus with her partner, she is not able to conceive. The patient has been tried with letrozole and clomiphene citrate for ovulation induction, but it failed. So, what is the next step in management and how are you going to prevent ovarian hyperstimulation syndrome? So, this is the case 1 which are given to you. So, what we have to do is that now we are going to break this clinical case scenario into various fragments. So, now the most important points which you need to consider when you see a clinical case is that what is the age of the female. So here she is a 28-year-old female. So she comes under the reproductive age group. And the second important point they have given here is she is a known case of polycystic ovarian syndrome. And polycystic ovarian syndrome and infertility are interlinked to each other. And in patients of PCOS, we know that there is an ovulation, and an ovulation is the cause of infertility in patients of PCOS, right? So she is a known case of PCOS, and now she is complaining of infertility. So the presenting complaint with which this patient came to us is infertility. So when are you going to define infertility? Infertility is defined only when both the partners have unprotected coitus for a period of about 1 year. So even after having unprotected coitus for a period of 1 year, they are unable to conceive, then they can be taken as a case of infertility. So with respect to 28 years old and infertility, now we have to decide upon the management. But then they have also given us that the patient has tried with letrozole and clomiphene for ovulation induction. So this gynecologist has tried letrozole and clomiphene citrate for inducing the ovulation in this patient. Why? Because in patients of PCOS, the most common cause of infertility is an ovulation. So I always used to tell that whatever the presenting complaint, you have to treat that. So here anovulation is the cause for this infertility. So you have to induce the ovulation. So the gynecologist tried with the most commonly used drug for ovulation induction in patients PCOS, that is letrozole. So letrozole have failed to induce ovulation, and then the gynecologist has also tried clomiphene citrate, which has also failed. So both these drugs, which are the first line of management for the ovulation induction, has failed. So now what is the next step are you going to do in this patient, and how are you going to prevent ovarian hyperstimulation syndrome? So this is the basic question which has been given to us. Now we have broken this question into various fragments. So now let's solve this case. So now I taught you in the theoretical sections that when the first line of management, that is letrozole and clomiphene citrate, has failed for ovulation induction, then the second line of management will become human menopausal gonadotropin. So failed ovulation induction with letrozole and clomiphene citrate is an indication to start the patient on human menopausal gonadotropin injection. Right? So the next step we are going to administer in this patient is human menopausal gonadotropin. Okay, this injection human menopausal gonadotropin has to be given for about 12 days, right? And we need to follow step-up protocol. What is step-up protocol? That is, while giving this drug, we need to do some serial monitoring. So you monitor the follicles, you monitor the estrogen levels, and then you give the injection the next day. So every day you're going to give injection human menopausal gonadotropin, and after you give the injection, you ask the patient to come the next day morning and you do the monitoring. So what monitoring has to be done and when it has to be done, it will be discussed further. But as of now, you need to remember that injection human menopausal gonadotropin is the next step of management in this patient, because the indication is failed ovulation induction with letrozole and clomiphene citrate. So now we have given injection human menopausal gonadotropin. So once you give injection human menopausal gonadotropin, multiple ovarian follicles in the ovary will start to grow. And the one important formula which I want you all to remember with respect to human menopausal gonadotropin is each of the ovarian follicle will release 200 picogram of estradiol. E2 is estradiol. Each of the ovarian follicle which is growing in the ovary will release about 200 picogram of estradiol. This is the formula which I want you to remember. So once you give injection human menopausal gonadotropin, multiple follicles will start to grow in this patient, right? So since multiple follicles is going to grow in the ovary, what is the problem is that each of this follicle is going to release 200 picogram of estradiol. But if multiple follicles are going to grow in the ovary, then it indirectly means that multiple follicles are ovary. Each of these multiple follicle is going to release 200 picogram. Each one is going to release 200 picogram. So therefore, the estradiol level is going to increase in this patient. So for that reason, in order to know whether multiple follicles are growing in the ovary, indirect measurement would be to measure the serum estradiol level in that female. If the estradiol level is going to be increased, it indirectly means that multiple ovarian follicles are growing in the ovary. Only then the serum estradiol level will be increased in the patients. So for that reason, you have to monitor serum estradiol levels. The normal serum estradiol level is between 500 to 1500 picogram per ml. 500 to 1500 picogram per ml. Also, along with this serial estradiol monitoring, you also need to do serial follicular monitoring. So there is a protocol, that is, when the number of follicles when doing the follicular monitoring is going to be more than equal to 3 follicles, and the size of these follicles is going to be between more than equal to 17 millimeter in diameter, and when the estradiol level, serum estradiol level is between 500 to 1500 picogram per ml, which is the normal level, it is the time for ovulation trigger. See, human menopausal gonadotropin grows multiple follicles. When multiple follicles are grown, these follicles, when it is going to be more than equal to 3 in number, and when the size of the follicle is going to be more than 17 millimeter in diameter, and when the serum estradiol level is between 500 to 1500 picogram per ml, it is the ideal time to give a trigger for ovulation to happen. So that trigger is given by injection human chorionic gonadotropin. Injection human chorionic gonadotropin is the ovulation trigger. So once we give this injection human chorionic gonadotropin, about 36 hours after giving this injection human chorionic gonadotropin, the patient is going to ovulate. Ovulation is going to happen. So once the patient is going to ovulate, there are 2 chances which can happen. Either the patient can conceive naturally, or you can retrieve the eggs from the ovary of this patient and subject it to in vitro fertilization, where the in vitro fertilization is the process where artificially the sperm that is the male gamete, and the ovum, which is the female gamete, are fused in the laboratory in a dish, and it is grown, right? And this embryo is later, it is then transplanted inside the uterus of the female. Is that clear? Yes. So this embryo transfer can be done on day 3 or day 5 after the process of fertilization. So here fertilization means the process of fusion of the male and the female gamete in the laboratory. So when you are going to fuse the male and the female gamete in a dish in the laboratory, it is called as fertilization. So after this process of fertilization, you can do this embryo transfer on day 3 or day 5 after fertilization. So after ovulation, we have two chances. One is to conceive naturally, or you can retrieve the mature ovum from the ovary and subject it to in vitro fertilization. Right? So this is the normal process which happens with respect to injection human menopausal gonadotropin. But if you are going to do this serum estradiol level monitoring in patients, and if the estradiol level is more than equal to 2500 picogram per ml, it indirectly means that multiple ovarian follicles are being grown in the ovary, and these multiple follicles have released, each one of these multiple follicles have released 200 picogram of estradiol. Only because of that reason, the estradiol level is increased to more than 1500. Normal is 500 to 1500. And here it has increased more than 1500, where it is more than equal to 2500 picogram per ml. So this suggests that if I am going to give an ovulation trigger now at this particular point of time, it is going to result in ovarian hyperstimulation. So since the risk of ovarian hyperstimulation syndrome is present in this patient, what are you going to do? See, the major purpose of doing this follicular monitoring and serial estradiol monitoring is to be sure that the multiple follicles are grown in the ovary. If the amount of estradiol is going to be more than equal to 2500, then it is a risk factor for ovarian hyperstimulation syndrome. So at this particular point of time, I have to withhold injection HCG as ovulation trigger. You should not administer injection HCG to such patients. Why? Because if you're going to administer injection HCG, it is going to act as an ovulation trigger, and it is result in ovarian hyperstimulation syndrome, because the ovary is going to get hyperstimulated, and all the follicles which are present in the ovary will just rupture, and it will release the vascular endothelial growth factor, which will bind to its receptor, and it will increase the vascular permeability, which will result in collection of fluid in the third spaces, resulting in ascites, pleural effusion, hydrothoracitis, and it can even result in pericardial effusion as well. Right? In order to prevent all these complications, and in order to reduce the risk of thrombosis because of hemoconcentration, you have to withhold injection HCG. Clear? You have to withhold injection HCG in such patients. Is that clear? Yes. So now they are asking a question to you. So now, instead of this HCG, can you administer any other drug apart from HCG? Yes, you can administer a drug which is called as leuprolide acetate as an ovulation trigger instead of injection HCG. So what is leuprolide acetate? So leuprolide acetate is basically a GnRH agonist, gonadotropin releasing hormone agonist. So this GnRH agonist will act upon the hypothalamus, and it will act on the anterior pituitary, and it will release the follicular stimulating hormone and luteinizing hormone. This FSH and LH will act upon the ovary, and it will act as an ovulation trigger. So instead of HCG, you can also give leuprolide acetate, which is a GnRH agonist, as an ovulation trigger. So this is one option which is available to us. And apart from leuprolide acetate, you can also administer cabergoline, which is a dopamine agonist, in a dose of about 0.5 mg at the time of giving ovulation trigger. Why? Because is that this dopamine agonist has a function with this ovarian hyperstimulation syndrome. What is that? This cabergoline 0.5 mg is going to inhibit the vasculoendothelial growth factor receptor. Since it is going to inhibit the vasculoendothelial growth factor receptor, this will prevent the patient from ovarian hyperstimulation syndrome. See, I told you that all the follicles of the ovary will rupture if the ovary is getting hyperstimulated, and once the follicle is getting ruptured, it will result in the release of vasculoendothelial growth factor, and this vasculoendothelial growth factor will bind to the receptor, and it is going to result in increase in vascular permeability. But the scapargolin, which is a dopamine agonist, it is going to inhibit the vasculoendothelial growth factor receptor itself. So since it inhibits the receptor itself, this will prevent the patient from ovarian hyperstimulation syndrome. Is that clear? So I've told you two important points. One is about leuprolide acetate, which is a GnRH agonist, which you can use as an ovulation trigger. The other is cabergoline, which is given at a dose of about 0.5 mg at the time of ovulation trigger, which is going to inhibit the vasculoendothelial growth factor receptor, and it will prevent the patient from the risk of ovarian hyperstimulation syndrome. Now, if there is a risk of ovarian hyperstimulation syndrome in a patient, can you do in vitro fertilization in that patient? The answer to this question is that the in vitro fertilization and embryo transfer has to be delayed in such patients where the risk of ovarian hyperstimulation syndrome is present. Why? Because is that the important formula here is pregnancy is going to worsen the ovarian hyperstimulation syndrome. Pregnancy worsens ovarian hyperstimulation syndrome. See, if there is a risk of ovarian hyperstimulation syndrome in a patient, you have to delay the embryo transfer as a result of in vitro fertilization in that patient. Why? Because is that if you're going to do the embryo transfer in that patient, the patient will become conceived, right? Once this patient is going to enter into pregnancy, then there will be formation of the placenta, and the placenta is going to release there is going to be formation of the placenta, and this placenta is going to form human chorionic gonadotropin. HCG is the most important hormone which is produced by the placenta, right? This human chorionic gonadotropin, this will act as an ovulation trigger, and this will result in rupture of the ovarian follicles, which is going to worsen this ovarian hyperstimulation syndrome. Is that clear to you? Let me repeat it once again. See, there is a risk of ovarian hyperstimulation syndrome in a patient who has recently ovulated, and from this ovulated mature ovum, in vitro fertilization has been done. But then the risk of ovarian hyperstimulation syndrome is still present in that patient. Now, the question is, can you do embryo transfer in this patient? The answer is to delay the embryo transfer. Why? Because is that if you're going to do the embryo transfer in this patient, the patient is going to get conceived, right? Yes, embryo is going to be situated in the uterus, so the patient is conceived. Yes, and there will be formation of the placenta, and this placenta is going to produce HCG, which is human chorionic gonadotropin. And HCG is well known as an ovulation trigger. This HCG is going to act on the ovary, and it will result in ovarian hyperstimulation. So the ovary will get hyperstimulated, and it will result in rupture of the ovarian follicles, and vasculoendothelial growth factor will get released, and it is going to result in increase in vascular permeability, and it will result in hemoconcentration, increased risk of thrombosis, collection of the fluid in the third spaces, resulting in ascites, hydrothorax, and pericardial effusion as well. So in order to delay that, since pregnancy is going to worsen ovarian hyperstimulation syndrome by HCG, you have to delay the embryo transfer. Is that clear? Yes. And the second important point is that once the patient is going to ovulate, right, you have given everything. You have given human menopausal gonadotropin, multiple follicles have grown, you have given the ovulation trigger, and for the luteal phase support. What is luteal phase? The luteal phase is the second phase of the menstrual cycle after ovulation. So after ovulation, for luteal phase support, instead of HCG, you can give progesterone. So progesterone can be used for the luteal phase support instead of HCG. Is that clear? Because HCG is well known for its ovulation trigger action. So for luteal phase support, instead of HCG, give progesterone. Is that clear? Yes. So this was the clinical case discussion of PCOS and ovarian hyperstimulation syndrome. See, the question was what is the next step in management and how you are going to prevent ovarian hyperstimulation syndrome. So we discussed about the next step in the management. So what are the steps you are going to do? We have discussed that is you have to give injection human menopausal gonadotropin. How are you going to do the monitoring in that patients, and how what is the next process you have to do after ovulation. You can do the retrieval of the mature ovum and subject it to in vitro fertilization. And if there is a particular risk, you have to delay the embryo transfer. And for luteal phase support, we have discussed everything. So this was the clinical case. First question solved. So the first question have been solved now. Now the second question is, how will you prevent ovarian hyperstimulation syndrome? See, before that, let me tell you one important thing. See, this serial follicular monitoring and estradiol monitoring can be done in a fashion where the patient can be asked to come on a particular day, and on that day you can maintain a particular time. Let's say, for example, between 6 to 8 p.m. you ask the patient to come to you, you give injection human menopausal gonadotropin and ask the patient to leave. The next day morning, the patient has to come to you again, and during that time you do the serial estradiol monitoring and the follicular monitoring. See, every day you're going to do a step-up approach where after monitoring of the ovary and monitoring of the estradiol level, you're going to administer injection HMG, right? And whether it has to be done monitored every single day or once in 2 days, it has to be dependent upon the case severity and the patient, right? Okay, so the second question is, how are you going to prevent ovarian hyperstimulation syndrome? So as we all know, the first important thing is that to do serial follicular monitoring and to do serial estradiol monitoring, because estradiol monitoring is an indirect indicator of how many number of follicles are growing in the ovary. Multiple follicles in the ovary, then the level of estradiol is going to be increased. It is because each of this follicle is going to release 200 picogram of estradiol. Clear? Yes. So first 2 point is clear. The third important point is that you have to withhold the ovulation trigger with HCG if the estradiol level is more than equal to 2500 picogram per ml, which means multiple follicles are in the ovary, because each of this ovarian follicle is going to release 200 picogram of estradiol. So since there is multiple follicles and estradiol level is increased, there is risk for ovarian hyperstimulation syndrome if you are going to give ovulation trigger with HCG. Is that clear? Yes. And as we have discussed earlier, for luteal phase support, that is after ovulation, for luteal phase support, instead of HCG, you can give progesterone as well. Right? Yes. And in patients of IVF, if there is a risk of ovarian hyperstimulation syndrome, please delay the embryo transfer, because you're going to do the embryo transfer in that patient because of formation of placenta and production of HCG by the placenta. Increase in HCG levels in this female, this HCG will act as an ovulation trigger and the ovary will get hyperstimulated and all the follicles will start rupturing and it will result in the ovarian hyperstimulation syndrome. So since pregnancy worsens ovarian hyperstimulation syndrome because of HCG increase during pregnancy, it can result in ovarian hyperstimulation syndrome. For that reason, delay the embryo transfer in patients with a risk of ovarian hyperstimulation syndrome. And the most important point is dopamine agonist cabergoline 0.5 mg. It is known to inhibit the vasculoendothelial growth factor receptor by dephosphorylation. Right? By dephosphorylation, it will inhibit the vasculoendothelial growth factor receptor. So this will decrease the vasculoendothelial growth factor phosphorylation and signaling, which will prevent the increase in vascular permeability and the syndrome complex of ovarian hyperstimulation syndrome. Right? And the most second important point is, instead of HCG as the ovulation trigger, you can also use leuprolide acetate, which is the GnRH agonist, which is a synthetic hormone. This GnRH will act upon the anterior pituitary. It will release the FSH and LH. This FSH and LH will promote the ovulation, and once the ovulation has occurred, the ovum will get released, mature ovum, which can be retrieved for the process of in vitro fertilization cycles. Is that clear? So this is all about how are you going to prevent ovarian hyperstimulation syndrome. So please take a screenshot of all these important points, right? So these are of great clinical significance. So I hope I have been very concise with respect to this clinical case discussion, right? So in case if you have any doubt with regard to this clinical case, you can write to me in the Makla Gmail handle so that I can verify it once and I can come back to you again. So let's meet in another clinical case solved in Makla, where we'll be discussing the another interesting case with respect to other topics in gynecology. right? Okay, until then, please keep studying.